Let's think about pathology today. And this is your first lecture on pathology. So we'll do this little bit of an introduction to pathology, pathological processes first, in very general terms, and then we'll look more specifically at musculoskeletal stuff. Now, when dealing with pathology, we're dealing with the study of disease. And there's another term that you'll come across, pathophysiology, which is the study of disease processes. So what's going on within that disease at a cellular level, at a chemical level, at a tissue level? What's the progression of it? What are the interactions? And so on. And we'll be looking at the pathophysiology of various conditions as we go through this course. Now, when somebody comes to you, they're going to present with something very general a lot of the time. And it may be something as simple as pain in a region. Well, what does that mean? We use something called the pathological sieve to try and work through what may be going on with that person. And as far as the pathological sieve is concerned, you need to consider the location of the problem. And then consider what systems are associated in that location. And then define it even more. Consider what organs or tissues are located in that region. And then you need to consider the possible disease options. And obviously, you will know your various classic symptoms of your different diseases so that you can do this. But when somebody presents with something in your clinic, this is the way you should be thinking. You should be thinking, okay, they've got pain in this particular part of the body. What structures do we have there? What systems do we have there? Can there be any associations anywhere else? And then work through the various things that could be associated with it. So for instance, it's Daisy, isn't it? If Daisy comes into clinic and says, I've got the most awful headaches, they won't go away. Then, okay, you do have, do you?
Yeah, I do.
Oh, right. Oh, there we go. Fortuitous. Obviously, what we're doing is we're considering her head. Now, for the sake of headaches, we can also put the neck in as well, because we will learn when we do the nervous system, and we look at nervous pathology and headaches in particular, that tension in the neck area can cause headaches. Okay? So we would take that area into association. So what do we have there? Well, we have the bone, we have muscles, we have vessels leading into the head, we've got sense organs, we've got the eyes and the tongue and so on, we've got joints. Think about the temporomandibular joint, the joints of the neck. And we have nervous tissue. We've got the brain, we've got the meninges, the layers covering the brain. We've got cerebrospinal fluid, all those sorts of things in that particular area. So then you need to start thinking, okay, where's this most likely to be? And you can start to do that by getting definition of the symptoms. So what's the pain like? Is it intermittent? Is it throbbing? Is it continuous? Does it only happen at night? Is it there every day, 24 hours a day? Is it progressively getting worse? And the answers to those questions will help you define whether or not it's a pain which is actually right inside the head to do with something going wrong with the internal cranial pressure or the brain itself or the meninges themselves, or is it simply something just to do with a scalp problem in terms of blood flow into the area? Or is it to do with tension in the neck? That type of thing. And we will see how the answers to those sorts of questions will help you start to pinpoint what it is that this person may have. So you may then decide, okay, this is nothing more than just tension headaches. It only occurs when she's stressed and tired. She's a city banker, so she's got a terrible workload, lots of stress, all understandable. Yeah? Or certain answers to those questions that I've just illustrated may make you think, oh, This actually sounds like it's going on deep inside the head. This is problematical. I don't like the sound of this. I'm going to refer her back to a GP with a letter so that the GP can then refer on to a specialist. And the various things can be done in order to investigate whether there may be a deeper problem going on there. Also, don't forget as well, headaches, we've got things like migraines. So think about the eyes. Are there any visual disturbances and so on? Yeah? Somebody may present, let's say we have a woman presenting with pain in the right iliac fossa. Now, the right iliac fossa is this part of the body here. So again, you need to think, okay, what have we got under here? Well, you've got parts of the digestive system. You've got the muscular system, the abdominal muscles. You've got female reproductive system as well. And pain in this area in a woman can actually be quite difficult to differentiate. Where does this lie? Is it to do with the gut? Is it to do with the ovaries, the fallopian tubes, the uterus? And again, you would then think, okay, perhaps this is to do with the gut, so let's ask about appetite, let's ask about bowel movement. Is the pain worse just before a bowel movement, during a bowel movement? Has there been a change from constipation to diarrhea or whatever? Ask all around that area. If all of that's fine and dandy, no problem whatsoever. Then start to think, okay, maybe we're dealing with the reproductive system. So any change in her period cycles? Is there any pain or exaggerated discomfort with sexual activity? All that sort of thing. Ask about a history to do with the person's sexual history and the reproductive system history. And then they may say, oh, hang on a minute, I've just thought. We moved house at the weekend and I was doing loads and loads and loads of lifting. So if you've drawn a blank on everything else, it may simply be muscle strain in the abdominal muscles. Yeah? Do you get the general idea of how you're looking at an area thinking, okay, what's there? What's associated with it? How can we start to divide it up? And then you just literally go through ruling out, process of elimination. And if you come to a point where, which you may do, whereby you think, okay, I'm still not sure about this, but tests may give me a definite answer, blood tests, x-rays, ultrasound, whatever, then it would be that you probably need to refer your patient back to their GP with a letter from you, saying your findings, saying your concerns, and then that patient may be referred on. And there are some laboratories whereby you can refer on directly yourselves. So some laboratories will accept direct referrals from you, all to do with private medicine, of course, and they will take bloods for you, they will do the testing, and they'll send the results back to you. And then you need to interpret the results, of course. So that's the pathological sieve. Now, let's just think about taking a case history. And there are some very general things that you need to do before you even speak to your patient. Okay, so you open the door, your patient comes in, or perhaps your receptionist shows your patient in, or something like that. As the patient's coming in, don't sit there with your back to them or whatever, you know, waiting for them to sit down and start. That's, first of all, that's extremely arrogant and rude. And secondly, you will miss vital information, or what is possibly vital information. So the first thing that you need to do is to observe your patient. Observe the way that they look. Observe the way that they walk. Observe the way that they sit. All of these can give indications as to what may be going on. So are they very, very flushed? Are they very pale, pasty-faced? Are they very sweaty? Have they got spots? Are they yellow? In which case they may be jaundiced. Okay? All of these things are very important. Are they walking evenly, or are they walking with a limp? Are they stooped? Are they extended back a little bit because they've got abdominal pain or something like that? So all these sorts of things can be clues. Put your patient at their ease. PX, here, you'll see me use it quite a bit. PX is shorthand for patient. Most of your patients are going to be nervous of you. You are the big guru with all the knowledge, all the information. They don't know that you're sitting there thinking, oh my God, what am I going to do? Okay? They believe that you know it all. And obviously you don't. Nobody knows it all. You can't possibly. You have a damn good idea, but you can't know it all. But they will think that you know it all, and they'll think that you have all the answers. Okay? So you're this big, powerful person sat behind the desk. They're going to be slightly nervous of you. And you see that an awful lot. I see that an awful lot. So put them at their ease. When they come in, get up out of your chair, go to them, shake hands with them. Yeah? That handshake can tell you things. Have they got sweaty hands? Are their hands icy cold and it's actually quite a warm day outside, or it's warm in your waiting room? Is the handshake very weak because perhaps they've got a problem with their grip? Yeah? Those certain things. As you shake hands with them, you could have a quick look at their hands. Are their nails bluish, or are they nicely coloured? Now, this is all stuff that you can check later on as well, but there's little clues that you can pick up. Apologise for keeping them if you're running late a little bit. Sit them down, ask them, you know, how was your journey? Or if they're a new patient, what I often do is say, oh, did you have trouble finding me, or was it quite easy? Oh, no, it's quite easy, so on and so forth. And then, you know, as I'm getting some notes out or something like that, I say, God, it's a shocking day today, isn't it? 2 minutes worth of chat can just put them at their ease a little bit, and they're going to be much more willing to divulge information to you.